Hello everyone, welcome to HIM 216. This will be the first in a series of lectures covering Chapter 2 in your textbook. I would like for you to turn to page 10 in your textbook. And we're looking at the abbreviations and acronyms, and again we just have an alphabet soup of acronyms here to look at. And then Chapter 2 is quite a bit longer than Chapter 1. On page 42, you'll find the chapter review exercises for this chapter, and you will be answering those questions 1 through 20. The glossary definitions are on page 44, and I encourage you to read through those before we begin this chapter. I'll just go ahead and tell you in the workbook for Chapter 2, it's on page 3 in the workbook. You're answering the glossary definitions for Chapter 2, 1 through 9, and then also you're answering the multiple choice questions 1 through 16. And as a reminder, you're only going to enter into the assignment the letter that corresponds to the correct answer. You're not typing out the answer. So going back to page 11 in your textbook, and you're probably going to find that sometimes I don't actually tell you what page I'm in the book, and I'll try to remember to make sure that I clarify that for you. Page 11 talks about the purposes of the health record, and it tells us that there are 5 main purposes according to Abdul-Hak's Health Information Management of a Strategic Resource. And this is actually an excellent resource book. In the bachelor's degree programs, they use Abdul-Hak, where we use the Sales HIT book, they use the Abdul-Hak book. And one of the important purposes of this health record is that it is a communication tool. So it describes the health history of this patient. It allows people that are taking care of this patient to communicate with each other and see what is going on in that chart. It is the legal business document for that provider. It goes to court. While it is technically hearsay, it has been determined that anything that was created in the normal course of business that is in that health record is the legal business record, and it is admissible in court. And then of course it's a huge source of data, and it's also used, the documentation in these records is also used for educational purposes. Now this slide says that the health record, one for each patient. We briefly need to talk about the difference in an encounter or account number and a medical record number. When a patient comes into a facility, the first time they come in, they're assigned a medical record number and they're assigned an account number. That medical record number stays with them throughout their life in that organization. But every time they come in for services, they get a new account number, and the charges that are associated with that encounter are actually attached to the account number for each visit. And so each account is separated, but we maintain one health record for that patient by medical record number. And actually, when you go into a master patient index and you pull up a patient's medical record number, you'll see all the different encounters. And you can choose one specific encounter to go in and review. There are many different forms that health records take. Some are completely electronic, some are completely paper, and then some are hybrid. Some documents are electronic and some documents are paper. Most providers are transitioning to an electronic health record. There have been some federal incentives for federal providers that see patients that have Medicare, Medicaid, and they have been incentivized to make the transition to an electronic health record. There are a lot of things that have to do with quality and quality reporting, and you need a health record that can identify those and pull them out and then transmit them to the federal government. So there are many reasons that the federal government is very interested in having all their providers transition to electronic health records, and a big part of that is monitoring quality. And actually, you may have heard of pay for performance, and if the quality is not there, the providers are going to financially penalize. The payers are going to be Medicare and Medicaid in particular will financially penalize the providers if they don't have quality of care. So there's a huge switch to transition from paper to electronic, but there are some providers that still have paper records. And so but typically the content is the same. When we have transitioned from a paper record to an electronic record, really the paper process, the forms, the documents, they're all the same. We just transition them to an electronic environment. We still have a face sheet. We still have an H&P, a discharge summary, nurse's notes, notes for different ancillary services. So they just go from being paper to being electronic. Now, there are some very specific guidelines for medical record documentation. They have to be complete and they have to be legible, and CMS actually addresses this. It's actually addressed in coding guidelines. When you have, and many times state regulations also address this as well, as do regulatory. Joint Commission talks about complete and legible, dated and timed documentation in a medical record. So the content, there are documentation requirements for content. They have to be relevant. You have to have a relevant history. There has to be a current physical examination and the findings of that examination and the testing that was done. The physician actually has to assess the patient, create a clinical impression and a diagnosis. He has to create a plan for care, and he has to date and time that entry, and it must be legible. The medical record has to provide the rationale for any tests or services that are ordered. And another way of saying this is there really should be some medical necessity. If a patient has a headache, you wouldn't order an MRI of the brain as a first method of diagnosis. So the rationale for whatever is ordered should be clearly documented or easily inferred. You know, if you have a pediatric patient in the ER who has a fever and a cough, and you do a chest x-ray, you're looking for pneumonia. So these are the kinds of things we're looking at. Any of the past or present diagnoses that the patient has should be included in that medical record for the physician who's treating the patient or any consulting physicians. If the patient has health risks, those should be identified. If they have allergies, if they have past histories of conditions that are going to impact their care, if they have a history of congestive heart failure, or they're a diabetic, or they have COPD, those should be documented. And then the patient's response to treatment needs to be documented. You should be able to go through that record and look at the progress notes, and then follow up with the physician's discharge summary to see how the patient responded to the care that the physician was providing. Progress notes are written on a daily basis, and they have to go in and they have to update or revise any diagnoses that they are treating that patient for. So for instance, I come in with chest pain and they determine that I've had an MI. That should be clearly obvious and documented in that medical record. And then of course, we use that documentation for coding purposes, and it's absolutely essential that the record be accurate and complete for coding purposes. When we look at the different sections of a medical record, and if you look at an electronic record, you'll see this. If you look at a paper record, you'll see this. There's going to be administrative data. So typically we look at things like the face sheets and the consents. For this information, when you've gone in to see a provider, they've asked you your name, your address, your telephone number, your date of birth, your next of kin, your insurance information, your social security number. All of that information is administrative data that is maintained on those patients. And then, of course, the consents for treatment. There's a general consent, and if you're having surgery or some special procedure, there'll be an additional consent for that. Then we have the clinical data. And let's see, I'm on page 12 in your book. We have the clinical data, and that is the clinicians, the people who see the patient, that put their hands on the patient. That's clinical data. So it can start in the emergency room, and then you can see from this documentation and the documentation in your book, it just includes anyone who sees that patient. Anyone who sees that patient has to document their findings. And it really kind of ends with the discharge summary. And the attending physician is responsible for creating this admission history and physical, and he's responsible for the discharge summary at the end. And then in between, he's writing orders for that patient. He's writing a daily progress note for that patient. Any providers that see that patient are writing progress note if there's a consultation. If a pulmonologist comes to see a patient, he'll do an initial consultation, and then if he comes in each day to follow up with that patient, he'll be writing a progress note. In that chart, if the patient has surgery, we're going to be finding the anesthesia forms. An anesthesiologist has to evaluate that patient before surgery, after surgery. The surgeon has to dictate an operative note immediately after surgery. The patient goes to a recovery room. Those nurses are documenting their care for that patient. And then any other ancillary work that's done, any lab, radiology, respiratory therapy, physical therapy, EKGs, all of that information has to be included in that medical record. Now, there are agencies and organizations that have requirements for this data. Joint Commission has requirements. They're an accrediting agency. The actual medical staff bylaws will document requirements. And then the federal government has guidelines. And truly, when I tell you the federal government drives health care, they absolutely do. Then we have the Universal Hospital Discharge Dataset, UHDDS, and we'll look at that. UHDDS is on page 13 in your textbook. Now, if you actually Google UHDDS, it's actually a much more extensive set of data, but this is the data that hospitals are entering. I want you to look on page 14 and 15. This is an example, of course, of a paper emergency room record, and you can clearly understand and see why going electronic is such a much better option for this documentation. Some of this is fairly legible. Now, if you don't have a good working knowledge of medical terminology and abbreviations, you'll have a hard time with this form. So, those are being able to kind of look at this and figure some of these things out is very important. And if you're coding it, of course, you do need to be able to read it and interpret it. It does include, when you're looking at the parts of these forms, the CC on page 14 at the top of that form is the chief complaint. Then we have a history of present illness. 51-year-old female with, that little C with the line over the top is the abbreviation for with. And lupus and failing renal, looks like treatment per patient. Last creatinine was 8. Something on 7606 per rejection of treatment. So anyway, when you look at this, you can see the current history, why that the history of this patient's medical condition that the physician is seeing. There's also a past medical history. The patient's medications are listed. Family FH on this form is family history. SH is social history. We have allergies. And then we have information about alcohol, where they live. We have a review of systems and then a physical exam. On page 15, we have the differential diagnosis up at the top. The physician thinks that she could have a stroke, uremia, an infection, or drug side effects. And he's having a head CT and lab work done for this patient. Then we can see that the CT showed no CT evidence of acute ischemia. And then we can see that this patient was seen by the attending physician. We have a procedure progress note. And when we look at that progress note, no acute neuro issues per CT of the head, patient accepted to medicine for uremia. And then our diagnosis is uremia. In the disposition, we can say that the patient was admitted and her condition was good. And so this is a great example of an ER document. Patients admitted to a facility or patients who are having outpatient surgery have to have an admission history and physical that is signed by the physician. Sometimes physicians have physician extenders, physician assistants, or nurse practitioners that dictate histories and physicals, and then they review them and sign them. There are some elements of an H&P that should be present. Those are listed on the screen for you. These are actually headings. When they dictate, they provide the information for each of these sections. And actually, if you'll look on page 17 in your textbook, this is an example of an admission history and physical. It goes on over to page 18, 19, and 20. And that information is very legible. It's typed up, easy for you to read. I was going to check. Usually history and physicals document the date and time it was dictated and the date and time it was transcribed. Those are very important dates from accreditation and regulatory standpoints. Those are not included on this document, but if you're looking at a paper document or an electronic health record, those dates will be very obvious. Order sheet. Look on page 21. Physicians write orders, and that is how the staff know how to take care of that patient. You can't do anything to or for a patient without a physician order. They absolutely control the care of that patient while they're in the facility. Of course, in an electronic record, orders are entered electronically. This is actually a written order. You can see that there is a place for a date and a time. The physicians do have to sign these orders. If they're electronic, they may still have to sign them because they may not put them in themselves. This order hasn't been signed. The one dated 10/19 at 6 p.m. Actually, none of these look like they've been signed. Now, when you look at that order for 10/19 at 11 p.m., on the right-hand side, you'll see it says done, and then there's a date and a time and some initials. That is actually the signature of the nurse or the unit secretary that took off that order so that the lab would come and perform that lab work. So all patients should have orders in their chart, and those orders should dictate the care of the patient. I typically try to keep lectures at about 20 minutes, so I'm going to end this lecture here. Your question for this lecture is to tell me one of the purposes that a health record serves. So with this assignment, you open this assignment, and enter your answer and then submit the assignment. And again, that question is, what are one of the purposes that a health record serves? And that will conclude this lecture.